Think of the pulmonary artery as a highway, and think of the hypoplastic native aorta as the on-ramp.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
So Alice, will you remind our listeners what we do here at the PedsCrit podcast?
Absolutely. PedsCrit is an educational PICU podcast. We're looking for the best teaching spiels we can find, put them in podcast episodes, and make them available to all.
Yes, and we have a very special guest for us today. Is that right?
Yes. Today we're talking to Dr. Greg Yurasek. Dr. Yurasek is one of the best teachers I know. He went to Columbia University College of Physicians and Surgeons. He did his peds residency in Boston, followed by his pediatric cardiology fellowship at Boston Children's and a PICU fellowship at Mass General. He's now been a CICU attending for years and is the director of critical care simulation at Children's National.
Yes. And today is part one of a multi-part series on single ventricle patients and the postoperative Norwood. So part one really is a quick overview of single ventricle physiology, how to optimize these patients prior to going to the OR.
Let's get right to the episode.
Welcome back to PedsCrit. We are so excited to have Dr. Greg Yurasek here with us. Greg, welcome to the podcast. Welcome back to the podcast, I should say. To get us started, will you tell us something about yourself and include something you enjoy outside of medicine?
Oh, it's great to be back, Zach. Let's see, something about myself. Well, I was just talking to Alice and Zach about how I have twins and how they generally destroy my house. So that's something about myself. Something outside of medicine, I love distance running and I love skiing. Skiing is a little rough here in the mid-Atlantic when it's 50 degrees every day in winter, but hopefully some snow will come soon.
Fantastic. Outside of your clinical time as a cardiac intensivist, what are your other professional interests?
Well, I do lots of simulations. I run the critical care aspect of the sim center for the hospital, and I run the education for the cardiac ICU. So I think if there's one big way to put it, I would say trying to find a link, if it's there, between good educational approaches with simulation and actually engineering quality and patient improvements. Tough link to find, but that's kind of what I've been up to for the last few years.
Very interesting.
I have attended one of his ECMO cannulation sims, and I look forward to attending more.
Excellent.
So Greg, if there's a PICU or even a cardiac fellow who is feeling that they're going to go down a similar career path to you, intensivist, cardiologist, education, simulation, do you have any recommendations for them as they're early on in the career?
You know, it's funny. My path, I did cardiology first, and I have to be honest with you, I was not totally convinced that I was going to go into critical care. I actually was leaning towards doing cath. And then I spent a couple of additional months, I guess that would have been my second year in the CI, and kind of fell in love with that. I enjoyed sort of the opportunity to watch kids through a long period of time. And I think that the difference that I saw between that and other aspects of critical care medicine is that the length of stay can be long. And so you kind of have a clinic in addition to being an intensivist. You know, you're going to know these families and these kids for weeks and sometimes months. That is one of the things that attracted me to it. But as far as like advice for the fellow that's interested in it, just take it all in, relax, and enjoy the ride. And if it's something that you should do, it'll just kind of call to you. You know, don't force it.
That's perfect. Thank you so much.
All right. Last but not least, Dr. Yurasek, do you have any conflicts of interest related to today's topic?
I have no conflicts of interest. Thanks for asking.
Mm-hmm.
Perfect.
So let's start with the case, and then we'll talk about the single ventricle physiology basics and get ourselves to the Norwood. So you've got a term 3-kilogram boy who has a known prenatal diagnosis of hypoplastic left heart syndrome. He's admitted to the CICU. The parents already met with the cardiologist at your institution, and they are planning for a single ventricle surgical palliation. Greg, what do we even mean by single ventricle physiology?
A good way to start here. So single ventricle physiology, the best way to define it would be you've got one effective ventricle that is pumping systolic outputs to both the lungs and the body. You can get more detailed than that, and I'm sure we will get more detailed than that, but that's probably the way to put it. You just don't have a partition, so to speak, where you have a ventricle that's pumping blood to the lungs, a second one that's receiving oxygenated blood and pumping it to the body.
I've been told that one of the markers of single ventricle physiology is that the saturations going to the lungs are the same as saturations going to the body. Is that a fair way to describe it?
Yeah, that's perfectly good, Zach. Absolutely.
Greg, before we get into the nitty-gritty of management, what is the Norwood operation? What's happening here?
To start, I like to think of it as you sort of need three things in order to be a successful single ventricle palliation. And this is a nice way to put it together, I think, because this works preoperatively, immediately postoperatively, and really all the way until kiddos get their second surgery. And the three things are as follows. So the first thing is you need systemic circulation that is robust and predictable. And I think anatomically, we're going to get to this when we talk about the Norwood, you need an unobstructed way to get blood out to the body. So you're going to need to take whatever blood makes it back to your single ventricle, and you're going to need to get it out to your aorta or your neo-aorta in a way that is predictable, it's consistent, and it provides good oxygen delivery to all of the key organs. The second one is what I would say as controlled and predictable pulmonary blood flow. And by this, one of the issues that we often see early on in single ventricle palliation, certainly preoperatively we see this, and we see this soon after a stage 1, is a little bit too much pulmonary blood flow. And there's a reason for that. But the idea of a Norwood procedure or any procedure that involves a shunt is to provide a source of flow to the lungs that's consistent, predictable, but it's also limited. And when patients have a ductus, which is typically how a lot of these patients will be managed and anatomically how they're going to be structured before they go to the operating room, things get really unpredictable. And it's very hard to sort out how ductal blood flow and pulmonary versus systemic vascular resistance can be predicted in a meaningful way to say this kid's going to be great if we go to the OR tomorrow or the next day. That's a really difficult skill to develop. But what can be done is after the operation, or I should say as part of the operation, the shunt that is put in to the lungs is one that provides consistent blood flow, but it's also limited in a way that it doesn't steal so much from the system. And then the third thing is probably conceptually and surgically the easiest, which is that the blood that comes back from systemic circulation and from the lungs has got to be mixed completely, right? There's no place for any kind of gradients at the atrial level in a good single ventricle setup. So we need complete atrial mixing, and so surgically that will end up being what we call an atrial septectomy. So those are those three kind of big things. We need robust, predictable, solid systemic oxygen delivery, limited, predictable, but adequate pulmonary blood flow, and then we're going to need good atrial mixing.
Excellent. When you think about the language of stage 1, interstage, stage 2, stage 3, how would you define those terms?
If we're going to speak specifically about a hypoplas, and I think we'll focus our conversation specifically on that, a stage 1 for that would be a Norwood procedure. So that would mean the creation of a neo-aorta, the creation of some sort of shunt that's going to bring blood from either the ventricle to the lungs, that's called a sono shunt, or from a systemic vessel, like the innominate artery to the lungs, that's called a BTT or Blalock-Thomas-Taussig shunt, and then the atrial septectomy. So that's kind of the stage 1 procedure. Interstage is going to be all of the time in between the moment that circulation is established and a cavopulmonary anastomosis, which is a Glenn, which is when that systemic to pulmonary shunt is taken out, and the superior vena cava is anastomosed typically to the right pulmonary artery, so that all of the blood from the arms and from the head go directly to the lungs.
And is it fair to say that the Norwood or stage 1 procedure typically happens in the first couple weeks of life, and maybe the Glenn is 3 to 6 months?
That's very fair, Zach. Absolutely. Typically most centers are due a Norwood within, say, 5 days of life. Typically at that time, patients have done what we call transition, which means they're sort of getting used to being a baby instead of a fetus. The pulmonary vascular resistance is dropping. There becomes usually a solid amount to even too solid amount of pulmonary blood flow, and that generally lets us as intensivists and surgeons know that they're ready for that procedure. And then, as you suggested, usually 3 to 6 months. That sort of changes depending on the size of the child, the growth of the pulmonary arteries, how cyanotic the child is. Sometimes we'll wait a little longer if they're not cyanotic, but 3 to 6 months is a perfectly good range.
And many of these patients may also progress to the ultimate destination of a Fontan, correct? Maybe age 3 or so?
That's right, yeah. And that's changed in the 10 years that I've been doing this. We were doing Fontans at closer to age 2 in around the 2005-2010 range, and we're often waiting a little longer now. There's a few reasons for that, but yeah, age 3, 4, something like that. The idea is getting good linear growth, good development, getting nice space between the child surgeries. All of those very, very important things, but also not waiting too long with the Glenn circulation, which can have some implications. So yeah, about 2 or 3 years of age is average.
And I failed to actually define a Fontan. Will you do that for us?
Sure. The Fontan conceptually is the easiest of all the operations, I think, because essentially you already have the SVC going to the PAs, but the inferior vena cava and anything below the heart, all of that venous return is going right into the common atrium, right? It's not going to the lungs. And what you're essentially doing is you're either by taking the IVC off of the right atrium, so to speak, or tunneling it through such that there's a barrier between the Fontan pathway and the common atrium. You're basically baffling all of that IVC blood right up to the Fontan, meaning it's going to join all of the blood that's coming from the SVC, and there in turn all of that is going to go to the lungs. So essentially all systemic venous return will go to the lungs first before going to the body.
Nice. If we zoom out here, we're thinking about the Norwood. Which types of cardiac lesions might be managed initially by the Norwood?
Well, you said first one, which would be probably the most classic and also probably the most common, which would be hypoplastic left heart syndrome. And I think the nice thing with that is a lot of the anatomic diagnoses that would sort of lend themselves well to this operation are similar conceptually. So if your left heart is small or insufficient in some way, or your mitral valve is problematic or small in some way, or your aortic valve is problematic in some way, all of those are going to lead to a problem for systemic oxygen delivery, right? So if all the issues are on the left, then presumably the right heart will be well developed, the pulmonary artery will be well developed, the tricuspid valve will be well developed. And so the issue is all on the systemic side. When you're doing a Norwood operation, one of the key things that has to happen is there's got to be a creation of a new systemic outflow, and that's this idea of a neo-aorta. And typically with any Norwood or Norwood type operation, the pulmonary artery is going to basically be harvested to do that. So there's going to need to be a connection between the patient's native aorta and the new aorta, if you will, which is the pulmonary artery, and that together is what we call the neo-aorta. A lot of the times when I remember thinking about this when I was a first-year cards fellow, I think, well, I mean, if the aorta is so hypoplastic and there's no blood that's going through it, why do we need to bring it in at all? And obviously it dawned on me as it's dawned on you, well, the coronaries still come off of the aorta, no matter how small it is. And if you have a 2 millimeter ascending aorta, which is not uncommon with hypoplastic left heart syndrome, it's basically just a coronary artery. That's all it is.
Wow.
Right? And so you need to bring it into the pulmonary artery, and that particular anastomosis or connection is sort of the first part of the Norwood operation. What I think of when I think of that in my mind is think of the pulmonary artery as like a highway, and think of the really hypoplastic native aorta as the on-ramp. You need to bring those two together in a side-to-side fashion so that it's not obstructed, so that blood can go out the highway, but some of it can still go backwards onto the on-ramp, which is where the coronary arteries are a part of the patient's heart. Does that make sense?
Yes, it does. I do have a follow-up question. I will now disclose that very early in my training, and probably when I was post-call, I might have been sitting down to add a patient to the census, and I said in the CICU workroom, what do you call the hypoplastic rights? And 2 cards fellows in our 4th year said in unison, triatresia. What do you think about those kids?
Okay. Yes, it's true. As I think we've talked about on this podcast before, cardiologists love jargon. It's just part of their makeup. They can't help it. And intensivists tend to speak more just normally. And so I'm a bit of a mix of both. You got to use the jargon, but there's no reason to overuse it. So yes, so it is true. One could say hypoplastic right heart syndrome,
okay,
and encompass things like things that are very rare, like tricuspid valve stenosis, which is very rare, but tricuspid atresia, which is not so rare, or other issues where you have a very small right side, like a severely left dominant AV canal, something like that. For whatever reason, that is not typically what is done in the business. And instead, if it's triatresia, we call it triatresia. And if it's an unbalanced canal, we would call it an unbalanced canal. Those would probably be your 2 most common versions of hypoplastic right heart side, but we don't often use the words hypoplastic right heart syndrome. Conceptually, there's nothing wrong with it. Just if you say it out loud to a cardiologist, they may wonder what you're talking about.
Yeah.
I love the glimpse into the mind of a cardiologist that you give us here on the pod. So great. Lots of good background info here. We're kind of positioning where the Norwood actually fits into the context of many of these kids who have congenital heart disease. The first major focus I want us to lean into here is the clinical care of the single ventricle patient. And if it'd be helpful, we can focus on hypoplastic left heart. They're in the CICU. You're preparing them for their operation, their Norwood procedure. So tell us, what are those key preoperative considerations that you have for this patient? What are you worried about? What are you doing day to day for them?
That's great. And we can probably start with the patient that Alice mentioned, the 3.0 kilo bouncing baby boy with a known diagnosis, because I think some of that will help frame the conversation so we can kind of get, I think, to what you want to talk about, Zach. Because sometimes with postnatal diagnosis and kids who are either very, very small or premature, there's genetic concerns, this conversation is a little different. But if those things are not part of the problem, or at least part of the concern coming in, the overall thought is going to be really straightforward. Start the child on some prostaglandin as soon as they emerge into the world. And I want to make sure that makes sense to everybody, right? That's going to keep the ductus arteriosus open. So if you have a really small aorta, if you have a really small mitral and/or aortic valve and an insufficient left side, or if you have all of those things, you're not going to have enough systemic output. So as soon as the ductus closes, you're going to be in real trouble as far as systemic oxygen delivery. So what the ductus allows is the blood that's in the pulmonary artery to go right to left, or pulmonary artery to aorta preoperatively through the ductus to provide the systemic circulation that you need. If the patient has so-called aortic atresia, which means they have no blood whatsoever that's coming out the aorta antegrade, then the ductus actually provides all of the systemic blood flow right to left. So whether it's providing some of it or all of it, it needs to be open. And so prostaglandin would be something that we'd start right away. So typically these babies are born, umbilical lines are placed, they are not intubated, almost universally not intubated. It's much, much better if they're not, for a variety of reasons, all of which are pretty obvious. And umbilical lines, once they're placed, we start some prostaglandin. There are generally no vasoactives or anything like that that needs to be part of this, and the child's just assessed by the common consult services that would be involved in this child's care going forward. Genetics, NICU, neurology. These kids will often get some brain imaging, at least a head ultrasound, sometimes a screening EEG and an MRI. And while this is all going, what we're doing is we're waiting for the pulmonary vascular resistance to fall, which it will over the next 12 hours to 3-4 days and beyond. When it does is typically when we start to think about the operation. But it's kind of nice in that you usually have this half a week or sometimes more where you can do this diagnostic workup, but really importantly, get the family to know their child, right? These kids can be held. They can usually be orally fed. We were feeding none of these kids in 2010. We're feeding way more of these kids. I should just qualify that a bit and say by mouth. Tube feeding a child on Prostin gets some people a little concerned, and for good reason, and there certainly would be some risk for neck there. But orally feeding a child, I've never seen a hypoplast get themselves in trouble personally. Orally feeding, the ones that are sick just won't eat, and the ones that are feeling all right, they will. Sometimes some diuretics, Zach, are important in this, and that's just because as the pulmonary vascular resistance falls, the pulmonary blood flow increases. As the pulmonary blood flow increases, there's usually more things like pulmonary edema or at least interstitial edema, and that leads usually to resting, comfortable tachypnea. So a little bit of diuretic, a little bit of prostaglandin, sometimes some TPN with some oral feeds as a child wants, lots of time with the family, not so much time with the providers, and that's kind of how I would say is the perfect 3 to 5 days before the Norwood.
Oh, I love the focus on being able to hold the baby as much as possible. That's lovely.
It's really important.
When we're rounding on these kids, there's always a conversation about describing the balance or maybe lack thereof balance in their pulmonary to systemic blood flow. At the bedside, how can you infer whether the patient's in overcirculation or maybe not getting enough pulmonary blood flow?
That's a great question. It's probably the thing we talk about, to your point, Zach, before they go to the operating room. And honestly, it's going to be the thing we talk about when they come back too. When you think of the setup, I know this is a podcast, so, we don't have video or the ability to kind of draw, so it really helps to sit and draw these things. And when I'm on rounds, I do draw these things. Alice has seen some of my terrible drawings.
They're pretty good.
It is really, when you set this thing up and you draw it out, you realize rapidly that, wow, there's going to be a good deal of pulmonary blood flow. There is. As soon as the resistance goes down, it's a heck of a lot easier for a hypoplast, or really any hypoplast variant, to get blood out to the lungs, and more difficult, right? Because you got to get through the ductus to get blood to the body. When you think about that, all of these kids are over-circulated, which just means that they have probably more blood flow to the lungs that you want. But the real question you want to ask is their systemic output on notice or threatened or of concern, right? If they are eating by mouth, breathing in the 40s to 60s on a little diuretic, maybe the heart rate's 140, 150, the blood pressure via the umbilical arterial line is 60s over 40s, 70s over 40s, it really doesn't matter if the saturation's 95%, and it probably will be 95%. It's not going to be lower than 85% unless there's a real lung problem or if there's something else going on with the child. So what I try to get our trainees to look at more is, what's the child look like? Are the pulses bounding? Is the child actually got nice cap refill? Is the child's tachypnea tolerated? What's the overall appearance of the child? Are they spending a lot of time in the isolette? Are they spending a lot of time with the parents? Things like that help a lot. You're always going to have too much what we say QP, or pulmonary blood flow. That's unavoidable, and when you think about it, you actually can't control it. It's a fully dependent variable. You're at mercy of it. It's just going to happen, right? And really what you're trying to figure out is, does the child have enough systemic oxygen delivery? The other variable that we'll use a lot invariably, especially in a cardiac ICU, is lactate, which has a lot of use postoperatively, at least to me. Preoperatively, yes, if the lactate is 5 and all of these things are true, I would still be worried. But if all the other things that I said are true, whether the lactate is 2.5 or 0.5 does not matter. It's all about the overall constitutional appearance of the child. But all of those things together are, I think, the things that we use to be able to assess whether a preoperative hypoplast is moving along nicely, transitioning nicely, and getting ready for their operation.
What if you have that patient who maybe you're worried about their systemic blood flow? Maybe the pulsars aren't as good today as they were last night. Maybe the lactate's creeping up. Maybe the central venous sat is drifting off. What's your clinical approach to help optimize oxygen delivery for that patient? And if you will, kind of get into how intubation can change or affect the physiology.
That's awesome, Zach. And that we run into not infrequently. So I guess the first thing I'd say is sometimes you can keep it simple. Sometimes if the child's 4 days old, they're just telling you that it's time to go to the operating room, right? So the first thing I would say before we get into the medicine, and I promise we will, but is have a good relationship with your surgeons, and don't be afraid to reach out to your surgeons and say, listen, you remember this guy Smith? He's doing great, but there have been some subtle changes over the last 12 to 24 hours. Elicit the things you're actually seeing. This is different than yesterday. This is different than yesterday. I know that we said that we would go to the operating room for the Norwood on Monday, but it's Thursday night, and I think that tomorrow might be a better day, right? Now, a different patient, and I think kind of the one that you might be referring to, Zach, is what if this happens in a 36-hour-old baby, or maybe they're 2.4 kilos. Maybe the family is just getting used to this diagnosis and they don't know if they want to move forward with this. Maybe we need to do some things in the ICU to sort of optimize their circulation as best we can. And so one of the things that we'll do, exactly like you said, is to intubate. And of course, I remember hearing this when I was first a CARDS fellow, and I was like, well, this doesn't make any sense at all. This child doesn't have a lung problem, and they don't, right? But the idea of intubating the patient does a couple of things. The first and most important thing it does is it offloads the metabolic demand. As you guys and your listeners are well aware, something like 25 to 35% of all caloric output, from a child, even a child that doesn't have heart disease, is used for breathing, right? And that whether that's diaphragmatic muscles, which is kind of the main muscles, or intercostals, and also if they're awake, they're moving their skeletal muscles. All that stuff accounts to a lot of energy exertion, and that accounts for a lot of oxygen consumption. So we just talked about systemic oxygen delivery being a problem with a pre-op hypoplast. Well, if systemic oxygen delivery is sort of on notice and you're worried about it, then consuming a lot of oxygen should make you really, really worried. And from that idea, from that philosophy, follows pretty nicely. If I minimize oxygen demand, this kid's probably going to get a lot more stable, and they do. So that's the first thing, would be intubating the child, which usually can be done very, very easily because, this kid's not ever had their airway instrumented before, and they're usually not horribly shocky. They're just kind of getting to that point like you referred to, Zach. And so we could put a breathing tube in, we could put them on a ventilator, we can give them some sedation, make sure they're safe, and also give them on occasion, or even continuous in some cases, neuromuscular blockade. If you do all that, you will raise their mixed venous saturation some 20 points typically, and that lactate will clear in an hour. It'll also help you do some other things if it's a child who's really struggling. let's say you do that and you still have this feeling that there's too much pulmonary blood flow, even though you've removed basically all of the oxygen demand that you could use something called subambient oxygen, or people call hypoxic gas, and basically that would mean an FiO2 of under 21%. This is a temporizing measure. It's not something you want to do for days and weeks, but it is a way to intentionally increase PVR, something we rarely talk about. But in doing so, if you increase PVR and you're ductal dependent for systemic blood flow, by nature and by conclusion, you're going to have more systemic oxygen delivery. So to answer your question, just once again, just the idea you minimize metabolic demand, that's the main thing. But the other thing you can do is you can also have adjuvant therapies, which might improve your circulation even more.
That's so insightful. A great answer to the question I feel like we're always asking ourselves when we have that sick patient who hasn't gone to the OR quite yet in the CICU. Also, there's a conversation, we don't do it very often, but a conversation about maybe not ventilating the patient quite at FRC, maybe expanding them a little bit above FRC. Do you mind giving me some comments on how you might use an approach like that?
For sure, Zach. In fact, this was my Saturday night. We have a patient with, it's not a hypoplast, but a similar situation. The child is very small and has a number of extracardiac things going on. Is really just, we're still trying to figure out if they would be a candidate for surgery. Mm-hmm. And, what we did is we intubated the patient, and then essentially the approach that I took was basically using the ventilator as a vasoactive. So if you just have them muscle relaxed, of course the child must be muscle relaxed to do this, right? Because even an intubated, ventilated baby is going to breathe his or her pH to just about 7.40. That's what we do. But if you underventilate, which is a little different than actually ventilating them at less than FRC, you can do that too. I think the approach that I've taken is I don't necessarily try to ventilate them under FRC. I just give them a normal PEEP, but I will actually lower their rate to maybe like 18 or 20, like something pretty low for a neonate, but with normal breaths, whether you're pressure or volume controlling them, just normal amounts. You want the lungs to open and close, expand and contract in the normal way. Maybe you get them down to 728 to 732. You'll see a huge difference. The blood pressure will shoot up quite a bit. The saturations will typically come down into the 80s. The lactate will clear, and you can really use the ventilator as a vasoactive very well. You don't then need to use any other stuff that may have been put on this patient while they were sick, maybe like epi and stuff like that, which is really not good for these kids. So ventilating them can be really, really helpful to your point.
Oh, so theoretically, 3 possible ways on a vent to change the pulmonary vascular resistance. You've got hypoxemia with the subatmospheric gas. You've got the idea that you can stretch the lungs out so that maybe the PVR is a little bit higher because of the way that you've stretched the alveoli. And you've got, I'm going to have the pulmonary vasculature constrict itself by hypoventilating the child just a little bit so that the CO2 goes up, the pH goes down, and the pulmonary vessels constrict.
Yeah, I think that's a good way of thinking of it. And really, as we go down this road, you want to keep in mind that these are temporizing measures. Like if you're doing stuff like this, you want to make sure that the surgeons are well aware that you are, because they don't want to operate, and we don't want it either, are babies that are going for elective procedures like a Norwood operation to be already ventilated on a bunch of vasoactives and, neuromuscularly blockaded for a couple of days and a hypoxic gas, which could have effects on the PVR and the OR. There's a lot there. These are things that you do if you feel the situation is getting out of hand, but it's not possible to get to the operating room right now. But to Zach's initial question, if this physiology is evolving before you, your first call is to the surgeons to say, what are the reasons we wouldn't go to the operating room right now?
Mm-hmm.
I feel like every day in the CICU, it's just another trip to the physiology lab, and these patients display it almost as good as anyone.
For sure.
We had a note here to ask you about feeds, and you mentioned that you will PO feed well hypoplastic left hearts prior to the OR. Are there really anything else to say about that?
I agree completely with that statement. And there's now some decent data on that, which is always so hard to put out there and get everybody on board with it. And a lot of that is that there have been some really good studies that have shown that PO feeding is almost certainly safe in single ventricle patients preoperatively. The trouble with that is that every institution kind of has their own protocols, whether we limit them or we don't PO feed them at all, or we let them do what they want. And so it's been hard to have like a universal approach. But to answer your question, yeah, I think PO feeding has at this point been established as something that's safe for pre-op single ventricles. Whether they should be able to eat whatever they want or limit them is not totally agreed on, but some PO feeding is, I'd say, essentially agreed on at this time. Where I think most people get a little concerned, and I would definitely be in this group, is tube feeding these babies. To me, like, there's just nothing like letting the child decide if he or she wants to feed. I don't think I've ever, at least not in years, NG fed a pre-op hypoplast. It just, to me, is just no reason for it. You're putting nutrition in an organ that the whole point of this is you don't know if it's got the best overall blood flow. There's a huge runoff lesion. You just don't know what you're doing, right? And if the child's not feeling well, whether it's because they're tachypnic or because their splanchnic blood flow just isn't ideal, they just won't eat, and that's fine. That's safe. That's cool. You'll give them IV fluids and TPN and get them ready for their operation. But at least some PO feeding at this point is used in most hospitals preoperatively.
And we should also say, there's a catheter in their umbilical artery going through their aorta that may compromise splanchnic blood flow as well. So another reason to be concerned.
You're exactly right. And that's something where I think our neonatal colleagues have warned us about that for years. And maybe it's because our kids are bigger, or maybe their physiology is different. We haven't seemed to replicate those exact concerns in the CI. But to your point, we should learn from them and listen to them, and it does always give us a little pause before giving these kids lots of feeds, especially tube feeds.
Sounds good.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.